Okay, good afternoon, everybody. Thanks for being here. I know it's been a long day. It's been an exciting day. I'm sure you're all enjoying yourselves. I know that I am. The plenary was great. I had to leave it a little bit early, but I understand that it got out a little bit late, so we're starting a little bit late, but that'll be just fine. We have a really exciting topic, the wonderful world of exercise, what's new in CF care. I'm really personally very excited about this topic. I'm sure you are too since you're here. Before we get started, a few housekeeping items. We're going to have 5 15-minute presentations followed by 8 minutes of question time. The questions are going to be asked through the app on your phone. So you probably are used to this by now, but you'll pull up the presentation, you'll pull up this course, this event on your phone, and then you'll select the question Q&A at the bottom, and make sure that you're putting your questions in underneath the question tab and not under the discussion tab so that we can see them up here. And we will ask your questions. If for some reason there's a problem with that system, we can always, so it's a small room, we can verbalize them as well, but we'll try to use the system. So why are we having this on exercise? As you've probably heard and probably seen, and as you've known, exercise has been shown to have many benefits for people with cystic fibrosis, as you see on this list. And yet, we know that people with CF are less active than their healthy peers. Thankfully, with the advent of highly effective modulators, we seem to be in a situation where maybe there's more opportunity for exercise, and this may be one of the most relevant times for exercise in CF that we've ever had, because patients may have more energy to exercise, they may have more time to exercise if they're self-simplifying, they may be more motivated, and they have more hope for a future to live a lifetime of healthy living because they expect to live longer. So I can't imagine a more important time to be having this discussion, and I'm very grateful for all of our researchers who are going to be coming up and presenting. So without further delay, we'll bring up our first speaker, Eleanor Main. She comes all the way from across the waters. She'll be giving our first talk.
Just bring this all the way down to my level. Can you all hear me at the back? Is that okay? Shall I get going with people still walking in? Yeah?
Go for it.
We're all good. So, hello everybody. I'm so lucky I get to do 2 talks today, and I guess what's interesting is that these 2 talks represent for me a kind of decade of research which involves exercise at our institution. But it struck me as I was preparing for these 2 talks that actually those 2 research studies come from very different places. The one that I'm going to talk about now it was a randomized controlled trial. And the one that I'll talk about a little bit later is a kind of a, you know what, we've got the wrong study up here. Actually, we should go back to Sean's, I think. There you go. Brilliant. So we'll try that one again, but at least you got a sense of both of the talks that are going to happen this afternoon. And so this one is a randomized controlled trial. The next one's a long-term observational study, and they come to the question from completely different angles. But I think you'll find that it's quite interesting that both of them start to hint at roughly the same thing. And so I hope that opens up some conversations a little bit later on in the afternoon. But it's my huge pleasure to present this particular talk on behalf of Sean Ledger, who can't be here. He's living on the very sort of east coast of Australia and high up and couldn't find funding, but I'm really delighted to be able to present this on his behalf. He was a PhD student of mine, and this project formed the basis of his PhD. And he was awarded, you'll be very glad to know, this PhD earlier this year in September. So it's a lovely moment. I think this study was undertaken between 2012 and 2016. And this randomized control trial, as you'll find out, had a very specific job within it. And the stuff that I'm going to present today is a kind of a strange offshoot of that, a little bit of curiosity, I think you'll find out. This study, this RCT, arose for an important reason. At around about that time, 2012, a whole lot of tiny little small-scale projects, including one done by Sean himself, had been showing that there was a benefit to supervised exercise in populations of people living with CF. And then the RCT police came out and they said, well, all of these little observational small-scale studies are fine, but you can't prove causation until you do an RCT. And so everyone took this very seriously, and they started designing a kind of long-term randomized control trials of exercise. And Sean's was one of them. Heberstrate's was another, and you'll be familiar with that paper that was published around December this year. And so that's how this study arose all those years ago. I have no disclosures to make in this presentation. And the INSPIRE CF study, I'll tell you very briefly. The trial design was a single-center, non-blinded RCT with parallel groups and intention to treat analysis. Intention to treat analysis. That doesn't always make sense to me, but I'm going to go with it for the time being. Funded by Great Ormond Street Hospital, and the ethics and registration of this trial are on the slide for you to see. You needed to have cystic fibrosis. You needed to be aged between 6 and 15 years. And the reason why that kind of slightly contracted age was that it was a full-on kind of 2-year trial of a supervised weekly exercise program. And so at the Great Ormond Street Hospital Clinic, you needed to kind of come in at the very latest at 15 years, so that by time transition arrived, you were 17, so you could stay in the trial for the time that was necessary. Participants needed to be able to perform spirometry and to have an FEV1 of at least 40%, and obviously signed consent. And people were excluded if they were on the transplant list or had been transplanted or did not provide consent. Very briefly, this was how the study worked. There was it's very, very faint up there, but 84 participants out of 176 were eligible to participate, and they were all invited and provided informed consent. And before randomization, participants had a multiple breath washout test, they had some spirometry, they had a CPET, and they had a 10-meter modified shuttle walk test and CFQR assessed as well. Now, I'm only going to present this afternoon the lung function test, but this is just to give you the full picture of what happened in this study. Then during the research project itself, on the left-hand side, the control group, who all had standard care at Great Ormond Street Hospital, but they also had repeat assessments at 6 months, 12 months, and 24 months. And on the right-hand side, the intervention group, who had current model of care, but every week they would also have an hour of supervised treatment exercise program. And this exercise program was specific to each individual. It involved high-intensity interval training, and it involved strength training. It was not difficult for patients. There were 4 trainers involved in this program. The trainers would go to patients' homes or patients' schools, or collect the child and take them to a local gym and do the exercise there. So it was a kind of really low burden, high supervision exercise program, and the kind of one that if you're going to sign up to any project, you might want to take part in. And then both of these groups all had spirometry, 10-meter shuttle walk, and they had the repeat of the baseline assessments at 6, 12 and 24 months. baseline demographics, this is only supposed to reassure you that after minimization, the randomization resulted in two very similar-looking groups in terms of gender, in terms of age groups, in terms of disease severity, most of whom were, in fact, very healthy indeed, with FEV1 above 70% predicted in terms of the area they came from, gene mutations, and endocrine function. So very similar-looking groups at baseline. This is just a tiny little visual to show you roughly what this looked like from my perspective. The training in the gym. Some of them look happier than others to participate. There's a lot of activity going on. And our primary outcome measure was an FEV1 Z-score using the global, the GLI equations, multi-reference, all ages equations that I'm sure are all familiar to you. The power of the study, 33 participants necessary, would provide 80% power, 5% significance in order to demonstrate an improvement of 10% in FEV1 over 2 years. And the study was powered on the result at 2 years. So this is it. This is the kind of the RCT intention to treat analysis. But first, an indication of how exercise attendance was for this study. There were 37 participants in the exercise group. Right at the top, attendance to exercise session, and if you can, pay attention to the first row, which has got a yellow highlight in it. The average attendance over 24 months. If you think about it, a weekly session over 1 year is 52 weeks, and a weekly session over 2 years is 104 possible weeks. And so the average attendance was 63%, which isn't bad. But if you look at the individual ranges of participation, this is a trainer coming to your house to take you to the gym to train you. The range there was between 16% and 91% of 104 weeks. And you can see that just summarized slightly differently. Total weeks trained, and that's the second yellow line that you come across. Of 104 weeks, 66 weeks trained on average, and a range there between 17 weeks only and an absolute stonking 99 out of 104 weeks. So someone really appreciative of the training on offer there. Slight differences in gender. So males were more likely to participate than females, but not a massive difference there. This is sort of classic bird's nest of FEV1 trajectory with a control on the left-hand side and the exercise group on the right-hand side. And indeed, it's always very difficult to find anything to see in these sorts of graphs. But this is it. This is the kind of RCT intention to treat analysis. And FEV1 Z-score, FVC, FEF, LCI, all of them are here. And if you glance down the red column on the far right, you'll see that the between-group differences in lung function revealed absolutely no difference after 24 months of exercise on offer. And so normally with intention to treat analysis, and I think, Thomas Reitker's just published this Cochrane review, which also indicates that it's kind of hard to find FEV1 differences with an exercise intervention. The Heberstreit papers showed something slightly worrying in the first 6 months, which is that it could make FEV1 a little bit worse. But here you see, again, kind of no real impact on FEV1 with this offering. And so that's normally where I would go home and say thank you for listening. But, you couldn't help thinking, and I know this is not what you're supposed to do in a randomized controlled trial, but you couldn't help thinking this is not like an RCT where you take a blue pill or a red pill. That's a single dose, isn't it? But when you've got some people attending 17 weeks of exercise, and some other people attending 99 weeks of exercise, it's very clear that there's a dose difference. And it does make sense then, if you have any curiosity in your head at all, to wonder if that dose difference makes a difference to the FEV1. So that's what we looked at. And Professor Angie Wade, who's Professor of Medical Statistics at Great Ormond Street Hospital and Institute of Child Health, helped us with this analysis. And indeed, there was a dose effect of exercise on FEV1 Z-score. And so those attending more than 52 weeks, i.e. More than half of the exercise sessions on offer, could expect to increase their FEV1 Z-score by 0.02 for every week that they exercised. And if you extrapolated this prediction model, those who participated in more than 52 weeks out of the 104 could improve by up to 1 Z-score over 24 months, and that might translate into a 7.5 increase in percent predicted FEV1 annually. And that is quite a big effect, isn't it? And so I think, the conclusions that I want to offer you today are, firstly, a kind of philosophical one, that, these participants who were offered on a plate the most extraordinary training with 4 very talented people. And, if there was a personality problem, so that, the girl wanted to be trained by a girl or a boy by a boy, all of those things could be accommodated and helped. But so I still can't, the philosophy here is, how could you make it easier for somebody to participate in exercise? And yet there were some that really struggled to get on board with it. So only, 16 out of the 104 sessions. And there were, on the intention to treat analysis, masked in all of this dose-related stuff, there was no overall difference in lung function between the groups, but this variability in exercise attendance allowed us to pick apart, to tease apart potential for dose. And we did find a dose-related response in those participating in at least half of the exercise sessions every year. And this effect was not observed in those who did not attend regularly. And the other thing was, it wasn't just FEV1, it was also FVC and it was also FEF, but it was not lung clearance index. That wasn't significant. And so we take away from this, I don't know how you get the horse to drink the water, but if you can get people to exercise regularly who are in your clinics, then there might be this hint, this offshoot of this randomized control trial that points to a dose-related effect that might be of clinical benefit. And so I'm going to leave you with that. Lots to think about. Children and young people with CF should exercise regularly. It didn't matter if you had severe or otherwise lung disease, and might, if they do so, gain some protective benefit in FEV1. So I'm delighted that you're here to hear all of this, but also very happy to take questions from the audience. Thank you very much.
Thank you, that was great. This abstract's open for questions. Now, we have a bunch online, but since I'm up here, I'd like to ask the first one. I have so many questions. This is, just look around the room, this is a great turnout for an exercise session at CF. This is really awesome, and I really want to thank the programming committee for keeping exercise on, the CF conference. And, this is just really a start of what we all can do. So exercise training is really difficult, and exercise training in kids, I think, is even more difficult. Attendance is great, but here's my question. Is there any objective data on intensity of the sessions or, of the exercise that these kids are doing?
Yes, so Sean collected all of this data, and there were 2 things that were required. So one was that they needed to, I think it was they needed to have reached a kind of level of in the visual analog scale, really, really tired. Each child had their own unique exercise program progressed so that when things became a little bit easier, they went up. All of them were exercise trainers, and so they made sure that these were sweaty sessions and heart rate was properly up with this kind of high-intensity interval training. I think it was clear that every child gave it their all during the hours that they were there.
Yeah, so it'd be interesting to look at efficacy of your FEV1 outcome and the actual intensity and the heart rate that they did. Great, thank you. So we have a few online questions. What do you think were some of the facilitators and the barriers to weekly participation? And did you identify any potential modifiable factors to increase that participation?
Yeah, I think that's a million-dollar question, and actually it's almost the entire focus of another PhD student at our institution is Helen Douglas, who's just submitted her PhD, but she looked long and hard at barriers and facilitators. And she in fact asked many of these youngsters that had been in Inspire CF what it was that made them happy to continue doing exercise. And she was interested in kind of maintenance of exercise behavior and wanted to know if there were any predictors for these things. And actually, in the early days when interviewing these kids, a lot of them said that being accountable to another, so having the exercise trainer and enjoying time with them and wanting to do well for them. So this accountability could be a supportive family member, but in fact it came up quite often, this accountability. Then she asked them all to fill in a self-efficacy questionnaire, and she found that people who enjoyed exercise and felt that they were reasonably good at it were more likely to maintain. She asked them all to fill in the Hayes questionnaire, and the Hayes questionnaire absolutely did not predict at all what people were up to, and she measured objectively, and we'll talk a bit about objective measures of physical activity in the later session today. But with all of these things, you could not reliably predict what somebody would do at home without measuring it. And so that's really, and it's completely different from person to person, whether it's accountability, whether it's self-efficacy. But I think everybody agrees that if you're going to get a child to exercise, then it needs to be enjoyable, fun, and the kind of sport that they can engage with. So.
And we'll go for one more question. Was there any assessment of adherence to their airway clearance programs? Would patients more adherent to exercise be more adherent to their airway clearance?
Yeah, it's a good question. And there was a very rudimentary assessment whenever an exercise session started. And it was mainly to screen for any potential unwellness. So they didn't want to do a high-intensity exercise program. And so it was, what are you coughing up and that kind of thing. But there was rudimentary screening in that respect, and when there were any concerns, then the CF team would be notified, but it wasn't formally part of the job for this study.
Great. And there were many more questions. I think that we'll have an opportunity to answer those questions through the portal. So if your question was asked and we didn't address it here, hopefully we'll have some discussion online. So thank you.
Thank you.
Thank you very much, Eleanor. Our next speaker is Lisa Falahi. She is a physical therapist from Yale New Haven Hospital and Yale University in Cheshire, Connecticut.
Hi, everybody. So my name is Lisa. I'm a physical therapist at Yale New Haven Hospital. and I also work with Yale University through the Winchester Center for Lung Disease in both the adult and pediatric cystic fibrosis clinics. The authors of this quality improvement project are myself, Alexandra Carbone, Elena Bokikio, Brittany McGowan, Dr. Gail Stanley, and Dr. Jonathan Koff. There are no relationships to disclose related to this presentation. So the quality improvement project is called Predicting Exacerbation in the Adult Patient with Cystic Fibrosis using a 1-minute sit-to-stand test. The purpose was to determine if there was a statistically significant correlation between changes in forced expiratory volume, FEV1, or percent predicted FEV1, and the 1-minute sit-to-stand test outcomes in patients with CF or cystic fibrosis transmembrane conductase regulator-related disorders. Just to provide a little bit of background information, patients with CF and CFTR-related disorders typically have exercise intolerance. So consistent exercise testing is really important to monitor for physical limitations and potential adverse reactions. The gold standard for exercise testing is the cardiopulmonary exercise test, the CPET, which measures peak VO2 or VO2 max, and is really not feasible for CF clinic visits and inpatient hospital stays during acute exacerbations, secondary to time commitment and allocation of significant resources. Some outcome measures, such as the 6-minute walk test, are also not always feasible due to time commitment and availability of space. The 1-minute sit-to-stand test is time efficient, easy to perform, and utilizes minimal resources and equipment. This model offers a novel method to predict lung function by performance of 1-minute sit-to-stand testing, providing objective data for clinicians involved in the care of patients with CF and CFTR-related disorders. The 1-minute sit-to-stand test requires the participant to stand up and sit down as many times as they can in a 1-minute time period. A standard height chair is the only required equipment, but for our purposes, we did use a pulse oximeter to monitor heart rate and oxygen throughout. Some information about who we tested. We tested patients with CF or CFTR-related disorders. We had 74 subjects, and we had a total number of encounters of 158. We did our testing when they were inpatient during a pulmonary exacerbation or during outpatient clinic visits during which FEV1 and percent predicted FEV1 values were captured. Only 2 of our subjects were on baseline supplemental oxygen. As you can see, our demographics, we had a wide range of people who were able to perform this test. We even had people in the 81 to 90-year-old age range, but primarily the age ranges were 31 to 40 and 21 to 30. Some more demographics, primarily female, but pretty even, and the primary diagnosis is CF. For our methods, respiratory therapists first obtained the FEV1 and percent predicted FEV1 values, and physical therapists assess the subject for medical appropriateness for the test. So some reasons why we wouldn't perform would be if it was a virtual visit, because we obviously wouldn't be able to obtain the FEV1 values. If the patient refused, which we all know happens, time constraint and unable to follow multi-step commands or unable to tolerate. 1-minute sit-to-stand verbal instructions and physical demonstration were provided to the subjects, and heart rate and oxygen values were obtained and recorded at the start of the test, at the 30-second interval, and at the end of the test. The total number of sit-to-stands performed were recorded. So a multiple linear regression analysis was performed to determine if there was a correlation between any of the data points collected and lung function. The data points collected included pre, during, post heart rate and oxygen, the number of sit-to-stands, the patient's sex, and age. Age and sex were the 2 most impactful data points in the multiple regression analysis. We did find a positive correlation between the number of sit-to-stands performed and the patient's lung function. It was statistically significant, but it's a weak correlation. Here you can see a scatter plot for the 1-minute sit-to-stand versus the FEV1 in liters. As you can see, it is a large cloud, not really formed around the best fit line. And this is our scatter plot for percent predicted FEV1. Just to highlight a case study, we had a 47-year-old male with a past medical history of bronchiectasis. We did his genotyping, and it was consistent with CF. He's on baseline 6 liters of oxygen, and he's currently on Symdeko as his modulator. He has chronic MRSA colonization and intermittent growth of Pseudomonas. He had stable lung function of 30% until recently. He's currently listed for transplant. His airway clearance regimen includes a well plan of VEST of 3 to 5 times per day, a sick plan of 4 to 6 times per day, utilizing the Minnesota protocol. For PEP, he uses the Arabica at least 3 times a day. Notably, he uses the Arabica more when he can't do as many VEST sessions. He uses huff coughs as needed, and he is currently in pulmonary rehab 2 times a week. This is just a graphic to show kind of when we were collecting his data, what setting it was in, what his FEV1 it was, his percent predicted, and the number of sit-to-stands. As you can see, we demonstrated a baseline number of sit-to-stands in 1 minute to be around 21. Unfortunately, we weren't able to collect all of the data in each setting, in each time, because he either was inpatient, and it's kind of difficult sometimes to coordinate getting PFTs while they're inpatient, and also sometimes when people have pulmonary exacerbations, they don't really want to do an exercise test. But as we can see, he was put on antibiotics. He had a pulmonary exacerbation, and he was inpatient. And then when he returned for his clinic visit post hospitalization, he still was not feeling well. You can see his number of sit-to-stands dropped to 13, and it took him a very long time to recover. We also see a desaturation to 88%, and it took him 2 minutes sitting to recover. However, during that clinic visit, he was prescribed antibiotics, and notably, he came back in a month and started feeling much better. We see a return of his lung function to about 27%, which was his new baseline, and his sit-to-stands did improve to 18. So in conclusion, there were no significant adverse events requiring medical intervention. So we found that the 1 minute sit-to-stand is time efficient, safe, cost-effective, and feasible test to administer, regardless of the setting. There was statistical significance, but it was weak correlation between FEV1 or percent predicted FEV1 and the 1 minute sit-to-stand test outcomes. The 1 minute sit-to-stand test can be used as another tool to detect pulmonary exacerbation and facilitate timely interventions. To just kind of cover some limitations of the study, it was a convenience sample. All of the patients that we collected data were from the Winchester Center for Lung Disease. It was a small sample size, only 74 participants and 154 encounters. It was difficult to coordinate same-day PFTs, particularly when they were inpatient, so a lot of times when they would have lower lung function values, we weren't able to actually use those data points. Frequently, we would get patient refusals. A lot of times when patients aren't feeling well, they don't want to perform any kind of exercise testing, despite encouragement. And of course, there's variations of administration of the 1 minute sit-to-stand test, despite all of our efforts to kind of standardize that process. And I would say the most important limitation is patient effort. You have to encourage them when they're performing the sit-to-stand, but a lot of times it would be difficult for them, some patients, just to really put in a full effort. For future direction, it was determined that the 1 minute sit-to-stand test is safe and feasible, and it can be used during telehealth visits. And telehealth visits were widely used during the global pandemic. By comparing their home spirometry and the 1 minute sit-to-stand test outcomes to their baseline values obtained in clinic, a change in their treatment plan could result in either an increase in airway clearance, medication prescribed by the doctor, a need for an in-person clinic visit, or inpatient hospitalization. We plan for further data collection and subgroup analyses. Here are our references. Any questions?
Thank you, Lisa. This abstract's open for questions. And we have one question online so far. Do you ever do a 30-second or a 5-time sit-to-stand if they can't tolerate the 1 minute?
No, this quality improvement project really just focused on the 1 minute sit-to-stand. because we do find that with time, these patients are fatiguing more quickly. So if they are not at their baseline for exercise tolerance. But that is an interesting idea. So we could try all that.
Was there any correlation between the 1-minute sit-to-stand and baseline exercise habits?
That's definitely an interesting idea. Yes, I just subjectively, yes. We had a patient who hiked all the time, who is very active typically in her day-to-day, and she has very low lung function, but she'd be able to perform 65 sit-to-stands in a minute. So it was pretty impressive with that lung function. So, subjectively, I would say yes. So, I think in general, the idea is we have to look at this case-by-case basis, that maybe the sit-to-stand could be utilized in certain patients who we know that they do have a clear difference when they are at baseline lung function versus when they're in an exacerbation.
As also a physical therapist who works with patients in a busy CF clinic, and we know we want to do exercise testing, but it's very hard to fit it in. I'm rooting for this 1-minute sit-to-stand test, the little guy. I want him to be good, and I know I'm appreciating your research because the more we learn about it, the more helpful it can be. One of the things that I've seen is looking at anthropomorphic characteristics of patients as well and the impact that could play. Mm-hmm. Did you look into height and weight as a factor, or is that something you've considered?
Yes, we did look into that, but we didn't find any specific correlations. Age and sex were the most impactful.
Is this something that you incorporate into routine evaluations in an inpatient setting?
Actually, yes. This is something that we really tried to keep standardized in the inpatient setting and in the outpatient setting. I frequently do it with my patients regardless if whether or not I can get PFTs. It's just those values weren't included in the project because we needed to have that data to correlate it. But yes, this is something that we do, and we actually even encourage our patients to perform it as a form of exercise, not just for monitoring for exacerbation. You'd be surprised at how exhausting it is standing up and sitting down as fast as you can for a whole minute, So this is something we encourage patients to do and practice and try to utilize in the future.
So kind of getting a little deeper question. I definitely agree that, we're rooting for this little guy. But, just because it's statistically significant, what's the clinical significance of that, you keep mentioning really poor relationship?
Yeah. I think with any small sample size research study, we're going to see really high effects with any kind of difference. And, I can say that we did have a bunch of outliers, patients who, with their lung function, arguably shouldn't be able to do as many sit-to-stands as they could, but they did. So, yes, it was a weak correlation. It was significant. Would more research, more participants, would we show a stronger correlation? Maybe. But I think the bottom line is, we need to see where this goes. This is a way that we can utilize exercise testing every day in clinic, and it's very fast, and we don't need any equipment. And, when I'm not in clinic, I have the respiratory therapist do it because it's that easy to perform, to instruct a patient to perform. So I think the long and the short of it is it just depends on the patient. And when you get a strong relationship with your patients, you'll know which patients that this is going to be impactful for. And, in our CF centers, we do create strong relationships with our patients. And I think most of us know which ones, this would benefit for, which ones are not going to provide a good effort, and the values are going to be skewed. So that's my answer.
All right, one last question for everybody who wants to do sit-to-stand in their clinic. Does it make a difference if the chair has arms?
A traditional sit to stand, you're not supposed to use the arms of a chair. I have noticed that especially when patients are in an exacerbation, they tend to go for the arms. So if you use a chair that doesn't have arms, that's probably better so that they don't use it. However, if you're going for purely just an exercise tool, I'm sure you could just use arms. That's also exercise, so.
Great, thank you.
Thank you, Lisa. Our next presenter is Cassandra Durella. She's a doctoral candidate in the Laboratory of Integrative Vascular and Exercise Physiology at Augusta University.
Yeah, there should be one in there too.
Awesome. Thank you so much for the introduction, and thank you to the organizers for inviting me to present some of our ongoing research. This is a rabbit hole I've kind of fell down during my dissertation work, kind of investigating muscle oxygen utilization and blood volume and how that differs during exercise between men and women with cystic fibrosis. Oh, thank you. I do not have any disclosures for this presentation today. Over the last several decades, we've seen a significant improvement in the median expectant survival age of men and women with cystic fibrosis, which we can account to a lot of the improvements in modulator therapies that we've observed. However, as we can appreciate on this figure presented on the screen above, women, highlighted in red, have a significantly lower median expectant survival age compared to their male counterparts, indicated in the blue line. This really highlights a gender gap or a sex disparity in the risk of survival and mortality of these women with cystic fibrosis. And it's driven a lot of ongoing research to try to better understand why this is occurring in these women. When we think about overall mortality and CF-related health, as we all are well aware since we're attending an exercise-focused session in CF, exercise capacity plays a very important role in the prediction of this. Since 1992, we've had a great appreciation that's grown over the last several years, understanding that individuals that have a lower exercise capacity, this is inclusive of both men and women with cystic fibrosis, those that have this lower capacity for exercise have a greater risk of mortality compared to those that have a higher exercise capacity. Let me get my little laser pointer out. And so Nixon and colleagues in 1992 found that this held true even when they covariated for the differences in lung function within these individuals with cystic fibrosis. More importantly, a few short years later, another study took a look at the relationship between the change in exercise capacity measured in VO2 peak and the change in lung function. And this was a longitudinal study, and this study further emphasized that there's no relationship necessarily between this change in exercise capacity and the change in lung function over time, really emphasizing that VO2 peak or exercise capacity plays a very important role in the prediction of CF health and mortality, and that we really need to understand how this plays a role further on. And for us today, it's important to note that there are differences in exercise capacity between men and women with cystic fibrosis, more often with women having a lower exercise capacity, but how this relates to their greater risk of mortality is currently really not understood. When we think about exercise intolerance, there's a number of different areas we can start to investigate to see how it contributes to this exercise intolerance. The first being the pulmonary dysfunction. The lungs play an important role in exercise capacity, but this is often not the limiting factor of individuals with CF unless they have a very severe or very low FEV1. So we've also taken a look at other avenues. Particularly our group and others have observed that vascular dysfunction plays an important role in exercise intolerance. And when we improve vascular function in these people with CF, we see an improvement often with their exercise capacity as well. There's also the level of the skeletal muscle in exercise, and that can play a role where the skeletal muscle may not be functioning as well and contribute to overall exercise intolerance. And that's going to be the focus for us today. And that's because the skeletal muscle is important for more than just, physical activity. It's important for day-to-day living. It's important for individuals to maintain their independence as they age. It plays a critical role in metabolism as one of our largest insulin-stimulated glucose regulators in the body. And then it is very, very important for energy production by producing almost like 90% of our ATP production through oxidative phosphorylation. And so this plays a very critical role. If any dysregulation in the energy production is going to contribute to a reduction in overall exercise capacity. And our group's actually really taken a look at this. So the skeletal muscle must efficiently extract the oxygen that's delivered and utilize it to produce ATP during exercise. And this was a study that we recently published from our lab where we looked at the oxygenation and deoxygenation levels of hemoglobin and myoglobin at the level of the vastus lateralis during exercise in healthy controls and people with CF. In the study, as we can appreciate by looking at these maximum workloads, individuals with CF highlighted in these dark closed circles had more oxygenated levels of hemoglobin at max exercise with lower deoxygenated levels, suggesting that they're not extracting the oxygen as efficiently at these maximum workloads. And when we gave a treatment of sildenafil, which is highlighted in individuals with the open circles, targeting that vasculature, so improving the blood flow and oxygen delivery, we saw improvements in the overall oxygen extraction in these individuals with CF, suggesting that if we give them more oxygen to the level of the muscle, that might help compensate. What we did fail to do in this study was extrapolate out if there were any differences in men and women, despite recognizing that there is a huge gender gap and sex disparity in their overall risk of mortality. And so that led us to the study that I'm going to present today, which is where we wanted to investigate if women have lower oxygen extraction and utilization during maximum exercise compared to their male counterparts. So all of our participants came through the lab and completed a maximum exercise test following the Godfrey protocol. And as you can appreciate by looking at the figure on the screen, we love to joke with our participants that we're trying to see how many things we can hook them up to for these tests. And one of those things is called PhysioFlow. And so this system allows us to non-invasively monitor thoracic hemodynamics throughout the exercise protocol. And so from this, the particular measure that we're interested in for today is the cardiac output measurement that we're able to obtain non-invasively. And we use this as well as with the finger pulse ox measurement and obtain a measurement of mixed venous O2 content during exercise, or SVO2. And so this gives us an idea of if oxygen delivery is matching the demand during exercise. And then from this SpO2 and SVO2 measurements, we can also obtain an estimate of O2 extraction. So these two measurements go hand in hand and give us an idea of everything overall. We also place a near-infrared spectroscopy, or a NIRS device, on the vastus lateralis of all of our participants. And this device emits an infrared light at two different wavelengths that is absorbed by the hemoglobin and myoglobin at the muscle based on its oxygenation status. And it's important to note that it can't separate out the hemoglobin and myoglobin, so it's kind of accounting for both of those measures at the muscle. And so this lets us track how the oxygen is being utilized and consumed during the exercise protocol, and we can see those changes throughout the protocol across the board. So far, we've had 10 men and 14 women of a broad age range come through and complete this protocol so far. We have had differences in height, with our men being significantly taller, as we would expect. Our men also had a greater absolute VO2 peak, and there was no differences in the percent predicted FEV1. Taking a look first at our baseline O2 delivery, demand, and extraction. So this is during a 2-minute rest period before starting exercise. We do not observe any differences in that mixed venous O2 or the O2 extraction at baseline. And upon maximum exercise, we also don't observe any differences between our men and women. However, when we start to take a look at the baseline measurements of this O2 utilization, the way this measurement looks is we have our oxygenated, our deoxygenated, and then a measurement of total hemoglobin across the board from that NIRS device at the vastus lateralis. And at baseline levels, we don't observe any differences between our men and women. However, when we start to look at the onset of exercise, when we see exercise, our women highlighted in the pink start to have a decline in their oxygenated hemoglobin myoglobin levels, whereas our men start to have an increase in this oxygenated level. The same pattern was observed for the deoxygenated level as well, and then the same thing with the total hemoglobin level. And so if we really focus on this total hemoglobin figure, which is also an indication of the total blood volume that's being delivered to the working muscle, this difference in blood volume with a decrease occurring in the women likely is contributing to that decrease across the board where we see an oxygenated and deoxygenated hemoglobin. And so we calculated the area under the curve for this measurement and just covariated for that in our analysis to see if this was impacting our measurement at all. And as we can see, this does impact it, and we no longer see that group by time interaction occurring. But we're still left with the question is, well, why is blood volume so different between men and women during maximum exercise? Particularly, why is it declining in the women during this maximum exercise when we would want an increase to occur? And so if we come back to this participant characteristics table, there's a few things that kind of stood out to us that we wanted to go back and look at. First, our men are significantly taller, so do they just have greater cardiac output, or are they just generally having more blood volume changes? And while we don't have statistically different lung function, if we look at that standard deviation, we haven't quite a range. And lung function or disease severity could very well be playing a role in this. And then finally, we do have a range of age groups across with adolescents as well as adults. And so we wanted to kind of separate out if there were any differences occurring with those adolescents compared to adults just by using the age of 18 as a cutoff point. So first we took a look at height and just covariated for that in our analysis, including both men and women. And so the same pattern was observed with our men having an increase and our women having a decrease in this oxygenated hemoglobin, the same thing with the deoxygenated, and the same thing with that total blood volume difference, suggesting that their height differences were not playing a role in that. And so then we took a look and did the same thing, but only now we covariated for that percent predicted FEV1 value. And we still saw the same pattern with the O2 hemoglobin, deoxygenated hemoglobin, and the total blood volume. And so the next thing we took a look at, as I mentioned, was we separated our groups out into adolescents versus adults. And so this first group figures that we're going to demonstrate are just the men and women over the age of 18, where we still saw that the women had this decline in their oxygenated, deoxygenated, and total blood volume across the board compared to men having an increase. And then we took a look at boys and girls, or adolescents, that were under the age of 18. And this pattern was no longer observed, suggesting that the men or the girls and boys showed a similar change across this maximum exercise test. And so this really indicated to us that there's some type of interaction that's occurring between age and sex that's impacting this blood volume during maximum exercise. And so I think it really drives a point as our people with CF start to live longer, we're going to start to see some age-related changes that we really need to start to better understand. So we need to start focusing on these men and women that are older and try to understand why these differences are occurring, and maybe start to target this younger generation with those therapies to prevent this progression from occurring. But we still have some work to do when we get back from NACFC. There's still some questions that I definitely have, as well as that I'm hoping to gain from you all today too. One of the ones that I really am interested in is, well, why do the men have such an increase in their blood volume? And the first thing that actually comes to mind to me when we look back at this figure, this increase in the oxygenated hemoglobin at these maximal workloads actually is kind of suggestive that they're not extracting enough oxygen out of the hemoglobin into the working muscle. And so I actually took a look at that with our measurements that we have. And so this is a figure that's just the men and women over the age of 18. And at baseline, their oxygen delivery and demand is similar between the men and women, and their O2 extraction is similar. And although this is a small cohort so far, some of our data suggests that these men are having more oxygen left in their venous system and less oxygen extracted at these maximum workloads. So is this increase in blood volume compared to the women a compensatory mechanism to try to increase that extraction level occurring? And so that we are still recruiting for the study, and so hopefully we can kind of tease that out in our men. But the flip side still is left too. Well, why do the women have a decrease in their blood volume when we would expect an increase during maximum workload? And I think when we look at these figures, it's really suggestive that the women are not utilizing it. They're extracting it, but it's not being utilized at the level of the mitochondria potentially. And in fact, this decreased O2 utilization is indicative that reduction in oxidative capacity. And our labs actually demonstrated that in people in general with CF, they have reductions in oxidative capacity at rest. And so if they have this mitochondrial dysfunction, and we don't know currently if it's different or worse in the women with CF. And unfortunately, we're not collecting that in this cohort of individuals coming through for this study, but we hopefully will start to collect some of that data and have it in another study and can kind of tease out, is their mitochondrial dysfunction worse, therefore having less oxygen utilization and reducing their overall exercise capacity. And then something I really would like to take a look at is actually the impact of sex hormones. We don't currently collect any of that here, but there's data in the literature suggesting that estradiol and progesterone have a negative impact on not only the lung pathology and disease infection in women, but some preliminary data I presented a few years ago suggests that estradiol negatively impacts exercise capacity in women with CF. And so we really need to understand those impact, and especially since there's a difference between the adolescent girls who may not be menstruating yet compared to these adults that are. So the fluctuations of hormones are really something we need to understand better. But so far, from this early data set, we are starting to see that older women with CF have a reduction in blood volume and potentially their O2 utilization during maximum exercise. And this very well could be contributing to their reduction in exercise capacity. And therefore, that might be why we see some reductions in their overall survival compared to their male counterparts. And I think it's really important for us to start to understand this relationship with exercise capacity, specifically in women, and their overall survival and how it differs compared to men. And I would just like to take a quick minute and make sure I thank all of our participants. None of this would be possible without their efforts to continue to come back to the lab and complete maximal exercise testing for us. Our lovely live P team who do a lot of the groundwork in collecting all this data, as well as our AU CF care team who constantly helps us recruit as well as our funding. And I am happy to take any questions today.
Thank you, Casey. This paper is now open for questions.
The difference that you saw in men and women with CF, are you aware of what it would look like in a healthy population on the same graphs? Can you elucidate that for us?
Yes, so earlier in the slides so there was a healthy control group in that first study I kind of demonstrated where it's collapsed together. But in healthy individuals, we see an increase in total blood volume, indicative, which we would expect, right? When you're exercising, you increase your blood delivery to the working muscle. And there's less O2 hemoglobin at those maximal workloads and more deoxygenated because you're extracting it out and utilizing it efficiently. So it would be to a greater extent. It's a little bit odd that we see a decrease in both the oxygenated and the deoxygenated in the women and an increase in both those avenues in the men. So we're still kind of trying to figure out why that's occurring.
Especially thinking if you're looking at like hormonal causes, you would think that you would see a similar trend one way or the other.
Definitely. It also would be interesting to take a look at like glycemic status as well and seeing how that plays a role in some of this.
So as questions come in, I got a question. Who's going to do all this work when you graduate in a few months?
I do not know. No, I think there's a lot of direction that could be picked up easily. A lot of promising things that we need to really tease out, and hopefully someone comes in and does that.
Political answer. Is there a reason that nobody with lower FEV1 values are included?
I don't remember what the cutoff for this specific study was, but most of the people that we were including in this particular study, this is all stemming from another ongoing study, so this was a direction I took based on the data we had. We could very well try to see if that impacts it. I think it would, but it was just based off of the actual direction of whatever the real study is looking at.
You mentioned glycemic index. Was there any look at whether or not the patients were sufficient or insufficient pancreatically?
So none of the participants included in the study had a diagnosis of cystic fibrosis-related diabetes. So we got HbA1c. I did not report that on here, and I don't actually even know it off the top of my head. But none of them were CFRD specifically.
Thanks, Casey.
Thank you.
Yes, thank you very much. All right, our fourth speaker is Brenda Button. She is Adjunct Clinical Associate Professor for the Department of Medicine, Nursing, and Health Sciences at Monash University in Melbourne, Australia. Thank you, Brenda.
Good afternoon, and thank you very much for inviting me to present this work to you today. This is really a culmination of about 7 years of work between my colleague Lisa Wilson, who was doing her master's, writing this up as part of her master's. And then the actual study we're presenting today is in collaboration with Lisa Morrison from Glasgow CF unit. And we were looking at the real-world use of the incremental A-step at 2 international centres. So today's main study is to really look at the next stage and to really look at our step test in a wider sense. So I have no conflicts related to this presentation. And background to the development of what we call the A-step, the Alfred step test, which is an incremental maximal effort step test at this point in time. We know that CPET is the gold standard exercise capacity test, but we also know that it's not universally available. When you look around the world, there are many countries that just don't have the equipment and the expertise, and even in our developed centres, often the equipment is expensive, operators need expertise, and there's also complex analysis, which isn't always available at the time that we do the tests for exercise prescription. So we identified the need for a field test that was suitable across the lifespan in CF. We'd previously used the 3-minute step test, but we looked at it in a couple of studies and really found that it had a ceiling effect in patients with FEV1s greater than about 60%, and the ones with really low lung function couldn't finish the test. It was too hard because it's a fast test. So therefore, we saw this gap that we don't have one test that we can use from childhood through to older age, where you can do comparisons over time. Space is a challenge in many hospitals, and we also now have strict infection control guidelines in CF, but also post-COVID, so that's added another layer of infection control guidelines. This need for this maximal step test needed to also include all aspects of lung function, age, etc. And our protocol and feasibility study have been published in pediatric pulmonology, which we'll talk about a bit more later on. So the overall objectives of the A-step were to develop an incremental maximal effort step test. We wanted to use outcome measures that were available in all clinics and in all hospitals, so nothing super expensive or difficult to achieve. We wanted to use clinic room space, so when they come to our outpatient clinic, we could do it in the space, and we needed to be compliant with our local infection control guidelines. And we particularly want to monitor exercise capacity over time and to measure the effects of new exercise programs for exercise prescription, and also to establish whether people with CF desaturate during exercise and need oxygen. This is the publication of the development of the A-step and the protocol, which people can access online, and we're also very happy to be contacted for any further information. And as I said, Lisa Wilson has written this up as her master's. The feasibility of the A-step we've just published recently in July this year, and this looked at from age 10 up to about 60 for the assessment of exercise capacity in people right across that range. So that's also available online. So now we come to the study that we're talking about this afternoon, and the aims of this one was to further test the A-step as a maximal effort test. And so we wanted to look at the feasibility in another population, another international population, and also a population on CFTR triple modulators. We in Australia have only started using modulators. It's only just been approved on April Fool's Day this year, whereas the group that we're comparing ourselves with in Glasgow had been on triple modulators for some time. So in the study, we partnered with Lisa Morrison and her colleagues in the West of Scotland CF service in Glasgow. and therefore we also wish to compare those on modulators versus those off modulators and to see if there was any difference. To further evaluate its usefulness, to review safety in another centre, and to establish if it's a maximal effort test internationally, and identify factors that may limit the ability to achieve a maximal test. So our methods are to use a widely available 20 centimetre non-slip step, measurements of blood pressure, oxygen saturation, heart rate, a metronome, which is a freely available app available for smartphones. It consists of 16 levels. Level 1 starts at 18 steps per minute, so that's really quite slow. And each level increases by 2 steps per minute. And at level 16, which is the last level, they are running at 48 steps per minute, and that's running fast up and down. A maximal effort test is achieved when they reach at least one of the following: a Borg score of 9 or 10 out of 10 for shortness of breath, which we would term lungs, and leg fatigue, which we would term legs, or heart rate of 90% for age predicted, which would be 220 minus age, or volitional fatigue, which is exhaustion. And the participants in the modulator naive group were from Melbourne, Australia, and those on Trikafta were from Glasgow, Scotland. This is our modified Borg scale that we use for all the studies. And these are our charts that we actually complete the tests on. On the left is the A step, on the right is our OR score, which is a quality of life questionnaire, which takes a minute to complete and really tells us how the patients are at the time on the day. So the results. So we first of all have the Scotland group, followed by the Melbourne group, mean and standard deviations. The ages are very similar, in the early 30s, mean age. FEV1 slightly higher in the Scotland group. Does this reflect that they were on gene modulators already, compared to 67 in the Melbourne group? FVC slightly higher in the Scotland group, 96 versus 81. MMEF much the same. BMI a little higher in the Scotland group, again probably reflects that they're on gene modulators, with just under 23 in Melbourne. Baseline SATs very similar, 97, 98. Peak SATs 94 in the Glasgow group and 95 in Melbourne, so we didn't have significant desaturation in either of those groups. Baseline heart rate very similar in the mid-80s. Peak heart rate 150 in the Scotland group versus 168 in the Melbourne group. Did our patients push themselves a little harder? The baseline Borg for lungs was 0 for both, and the peak was 5.2 for Scotland versus 8.1 for Melbourne. So it seems that our patients pushed themselves a little harder. Legs, the baseline Borg was 0, and the peak Borg was 5.4 for Scotland and 8.8 for Melbourne. So that looks again like they pushed themselves harder. And the number of steps levels, 9.8 for Scotland and 10.9 for Melbourne. And remember, it's an incremental test, so it's getting harder with each level. 6 of the 35 patients in the Scotland group, to our surprise, completed all 16 levels, and they were all on triple therapy, to remember, whereas 0 completed it in the Melbourne group. The number of subjects who achieved 90% of heart rate in the Scotland group was only about a quarter versus 2/3 in the Melbourne group. And the number of subjects who achieved greater than 85% of heart rate for age in the Scotland group was at 40% versus 82% in the Melbourne group. The number of participants who achieved maximal effort tests using those 4 criteria, 40% in the Scotland group and 95 in the Melbourne group. So it seemed the Melbourne group did push themselves a lot harder. So what were the reasons for not achieving a maximal test in the Scotland group? We had discussions about this, and one of them was inability to regularly change the leading leg. That was something that they really found in their testing. Development of early leg fatigue, therefore, was a major problem, and that made some stop. Inability to keep up with the beat was another problem in the Scotland group. And stopping the test early, and when we asked questions about that, they thought that maybe it was just possibly a lack of motivation. So the important lessons we learned from this about achieving a maximal effort test is that coaching the participant before the test is absolutely important, just like before CPET. Practicing leg changes at the end of a stage, it's something we need to physically practice in the clinic before we set off to do the test. Providing enthusiastic encouragement to keep up with the beat, so sometimes we actually have to talk them back into keeping going and catching up with the beat and keeping up with it. Cheering them on to push through and achieve a maximal effort test like we do in CPET. And educating the participant before the test that a maximal effort test means they need to achieve a 9 or a 10 out of 10 for lungs or legs, and sometimes both. That we're aiming to achieve a high heart rate, at least 85 to 90% for age. And the triple therapy really did appear to enable participants to complete the 16 levels. However, those participants were extremely fit. They had very good lung function, some of them even over 100% FEV1, and they were exercising every day. So they were a fairly unique group, but they certainly completed the whole test. And there were no safety issues for either of our groups. So our future directions are to consider using a 25 centimetre step in these really fit, normal lung function people with CF on gene modulators. And that's a study that we're going to start looking at between us. And because the test can be done in a normal outpatient space, it can be accessible for use in our clinics. So it's hopefully a test that we can really do on a more regular basis. Before COVID struck, we were doing the step test before every patient started gene therapy, going right back to the days of Orkambi, and then and Trikafta for those who were on compassionate use at our time. And now, of course, COVID stopped all of that because they couldn't come into the clinic. We're now getting back to it, but it certainly has changed our practice during that period. So we want to consider testing exercise capacity using this for annual reviews. And one of the things that we find really useful is that we can give real-time data we're getting at each exercise test, we can use with the patients. They're really interested in the results, and report the feedback to them as to how they did, what their heart rate did, what their SATs were. And having a look at that, you can really come up with a good exercise prescription for them. It provides assessment of desaturation during exercise. Do they need oxygen? Which, of course, on gene therapy, we're now starting to see less of, which has been another interesting finding. And to use to measure change after starting a new program or on new therapies. For motivation to exercise, which, of course, is what we're always trying to do. People with CF who've done the test have really responded very enthusiastically to it. Some of them have wanted to actually download and have downloaded the Metronome app and started using it a little bit as some training at home. But the main thing that we need to do is to validate the A-step using CPET, and that's something that's about to start when I get back home. So in conclusion, the A-step is a new incremental maximal effort exercise capacity test. It's been found to be safe, feasible, and efficient for use across the whole lifespan, starting at 10 years of age, and that's what's published in our feasibility study. They need good training prior to the test, so that's really important that they know exactly what they've got to do and what they're aiming for. And they need to change legs regularly throughout the test so that they don't get unilateral leg fatigue. We need to do active coaching as operators, and the test, of course, complies with our local infection control guidelines, so that's a bonus too. It's highly space efficient, and it's accessible, and so far has been appealing to most of our participants. And those are our two publications, one the protocol and the other the feasibility study. And I thank you for your attention and happy to take questions.
Thank you, Brenda. This paper is now open for questions. So as questions come in, I'll keep with the whole sex disparity theme. Do you have any idea of the composition of men, women, boys, girls in your two different cohorts and whether or not sex played a role in your results?
We haven't separated them out. We looked at BMI and we looked at FEV1, but we could go back and separate them out and have a look. I mean, it's a fascinating study that you've been doing and really leads to a whole lot of new thoughts, but that's something we can do.
I was wondering if you know about how long it takes on average to complete the ACE step.
Yes, 20 minutes. Once you get up and running and get with it and get used to it, probably about 20 minutes. From getting all the equipment out, doing the actual test, and then packing it away, like 20 to 30, depending on how long they go.
Sure, for the folks that completed the whole 16 stages, do you know how long that is? How long they're working?
Well, they're working, the actual test is taking them 16 minutes. 16 minutes, so a little bit longer. And that, of course, in that really fit group, that's a bit long. We're aiming to get it done in 8 to 12 minutes according to guidelines. So that's why we think if we can start that group at 25 centimetre step, then maybe they'll complete that in 8 to 12 minutes. But it makes it very doable in a clinic visit. So it's not such a time-consuming thing to do.
Brenda, question from the audience. Is there a video guide for the A-step test?
We have presented it online, and we haven't yet made a video guide, but that would be a very easy thing to do. It would be a case of finding the technology that could cope with it to be able to send it. I guess links and things, that would be something we can certainly look at. We haven't made a video guide yet. It's all written, and you can download that or ask us for more information. And our contact details are there, and my contact details are on the talk today. But we'll look into doing that. That's a good thought.
I'm thinking maybe an app. Create an
yes,
app.
We've talked about an app. It's one of those down the track wish lists after we've done the validation study. An app would be very good. What that actually involves in terms of money and time and all the rest of it, but yes, that's something that would be a great idea.
Question from the audience. Was there a standardized number of errors or number of chances you gave patients to get back on track prior to stopping the test? And at what intervals did you assess vitals during the test and post?
So the first part of the question was, how do we get them back on track? Usually by going up, up, down, down, up, up, come on, move faster, in that sort of way. And generally they could get back up again. They just sort of lost a bit of concentration, coordination. And we didn't have many problems with that. There were the odd ones who had a bit of a practice and then before the test started. But that was how we would have just been very practically vocal in getting them back. And then the second part of the question was?
What intervals did you assess the vitals?
Every minute. At the end of before and after the whole test, we did blood pressure, but we couldn't practically do blood pressure while they were doing the test. It wasn't feasible. So we did blood pressure, heart rate, oxygen saturation, Borg scores before and at the end of the test, and at the end of every minute we did oxygen saturation, heart rate, and Borg scores for lungs and legs. So in the last 10 seconds we'd say lungs, and they'd give us a score. We had it in front of them on the wall, and legs, and they'd give us the score, and then it would move on to the next step. So that was done at the end of every minute except for blood pressure. And then we had a 5-minute cool down recovery period where we continued to measure the same things every minute, and then blood pressure at the end of that as well.
So the theme of the meeting is including all people with CF. Any thoughts to trial on younger patients?
Yes, we have a colleague in Argentina who is planning a study to start quite soon in children, and they're going to go down to 8. They're going to see whether they can validate it from 8 years onwards. Whether they can cope with the coordination and sticking with it younger than 8 remains to be seen, but we'll go to 8 first and then see where we go from there.
How did you come to choose the 20 centimeter as a step height?
We did a lot of toing and froing for a very long time, and we tried it out with a number of patients. We have a few in our very early development. We had about 8 patients who worked with us to develop it, and we tried 15, 20, 25, 30. Some were too hard, some of them started developing musculoskeletal issues, and we eventually, through this trial and error, worked out that in our group, and we included some elite athletes as well. We had some basketball players who were very tall. And after all the toing and froing, we came up with a 20 centimeter. And we really wanted to try and keep the same step height so that we didn't have too many variables. Now, whether down the track we're going to have to move towards different step heights, well, we're already now talking about 25. But we didn't want to go with leg length and step heights and things like that, because that just introduced so many variables that it would make it difficult to then compare over time. So that was one of our goals, was to stick with the 20 centimeter step. But obviously this is a tool that's got this far. We've developed it a little further, and it's going to probably evolve a little bit over time. And there may be more modifications we may need to do. And of course, if any of you are doing any of these studies, that's very helpful if we can sort of come up with fine-tuning. But so far, that's what we've chosen.
And one last question, we'll let you off the hook. Most exercise programs are reported as VO2 max. Will you be able to do this with the A-step?
Well, that'll just depend. We're going to do a randomized study a week apart, where they'll do either CPET or the A-step. And whether we can get to VO2 peak, that may be our limitation, rather than the VO2 max, which is always difficult to get to in CF patients anyway, even on CPET. So I think our main goals will be to get to VO2 peak and be able to get an aerobic threshold and look at those sort of common measures.
Awesome. Thank you.
Thank you very much.
Thank you very much, Brenda. You guys are doing great. We have one more speaker. We're going to bring Eleanor Main back up. She's going to be presenting her actual presentation now. Eleanor is a professor of physiotherapy at the University College of London.
Is this the... Okay, well, thank you very much. Brilliant. So this is take 2. This is the impact of habitual levels of moderate to vigorous physical activity on FEV1 in children and young people with CF. This is results from Project Physio. And Project Physio kind of takes off. We did Sean's study earlier, and that sort of ended 2017. And Project Physio started around 2018 and went on through COVID to about 2021. And in Project Physio, it was kind of a real-world study. We measured 2 things for about 16 months. We measured them every day in a nice big cohort of children and young people with cystic fibrosis. And the 2 things we measured were airway clearance, and the other thing was physical activity. And today I'm only going to talk to you about physical activity. And if you want to really know what happened to the airway clearance part of Project Physio, you're going to need to come back and look at Emma Raywood's talk on Saturday, and she's doing a 9:45 session in the morning. And I'm only going to talk about physical activity today. So the thing, I'd have a big a team. This is hardly any of them. involved with Project Physio. It's a project very close to my heart, and I've really enjoyed being part of it. There are no disclosures relevant to this presentation. And I do not have time today to go into massive depths. I'm going to make it sound like it was all very easy. It was not easy to do. But if any of you are interested in having a look in some detail at the protocol and the methods for Project Physio, it has been published, and it's spelt badly, physio. So if you look that up, you'll find the protocol paper in the BMJ very easily indeed, and it's open access. So this slide will come as no surprise to all of you in this room. This is the World Health Organization's physical activity recommendations for children and young people, and they've tweaked it a bit, and the tweak involves saying that children and young people should do an average of 60 minutes every day over the course of the week. And if you do some maths on that, that means that over the course of the week, 420 minutes is what the recommendation is. And you and I all know in our hearts that not all children get involved with regular physical activity, and we don't know very much about habitual levels of physical activity in our cohorts of children and young people with cystic fibrosis. So we wanted to find out more about these habitual levels, but to go one step further, to find out if these habitual levels had any impact on clinical outcomes. So that's what Project Physio was all about. Everybody in Project Physio got given a Fitbit Ultra, and that's a version of the Fitbit that is not available anymore, but they've got other small versions. We chose the small version because some of the youngsters had very small wrists. And we had applied for and received permission to use extended access API, so that meant we could get raw heart rate data and footsteps from Fitbit. And what you can see on the bottom panel of this slide is that sort of red line, which is a theoretical MVPA threshold, moderate to vigorous physical activity threshold, and the equation that we used for the determining the threshold was person-specific. So we used every individual's own resting heart rate and peak heart rate from their modified shuttle walk test to determine their own MVPA threshold. And our job was every day to collect up the raw heart rate data and to collect all of the minutes in the day where the heart rate was above the personalized MVPA threshold. And then we'd sum them up and we'd find out how many minutes per day and per week were in MVPA. So that equation actually is one that works, there are a number around, but in pediatrics, this is the one that works the best in our experience. And so this is the data infrastructure of the project, remote monitoring of daily exercise over 16 months. We recruited 145 participants, aged 6 to 16, from 3 London CF centres. And that sounds like a lot of participants for a CF study, but in fact, it was a relatively low burden study. It involved wearing a Fitbit and synchronizing some data from time to time, so it was relatively easy to recruit to this project. And they synchronized their data, all their Fitbit data went up into the big Fitbit cloud, and we extracted it from the Fitbit cloud into our cloud, and then that went into the DRE. I think of a little laser pointer here. The data research environment was a secure environment, and in that space we reconciled the Fitbit and airway clearance data with all of the clinical records for individual patients, including genotype and lung function, microbiology, and all of that stuff. And I'll explain why we collected all of that data in a second. This is clinical data, and this is a kind of a cloud of data, which is all the lung function ever measured from all the patients at Great Ormond Street Hospital. And overlaid on that are 2 individuals, one in light blue and one in dark blue, taking a slightly different lung function trajectory over time. And so we used FEV1 data, as many people do, and will again, as our primary outcome measure. And you will know, as well as I do, that lots of things will contribute to an individual's trajectory of lung function, including infections or genotype or personal circumstances. So we needed to account for all of those things in our model when we wanted to find out what the unique effects of physical activity were on lung function. And so we collected an absolutely enormous amount of data, I think over 4 million data points from raw heart rate values, and that in the end was something close to 31,000 Fitbit days, or 5,200 weeks plus of physical activity data, which is a huge amount and healthy enough to get your analysis teeth into. And you can see here on this graph that this is MVPA minutes per day. And I've put a handy little red line across here, which is the World Health Organization recommendation of 60 minutes per day. And just for context, I've put a 30-minute dotted line down there. And each of these bars is an individual in Project Physio. And you can see at this end the median and range of physical activity every day. These people tended to achieve fairly regularly the World Health Organization recommendation. But you can see down this end there are a whole bunch of young people who were not achieving even the 30 minutes of moderate to vigorous physical activity per day. So this gives you a sense of the range of habitual behaviors at home and how we would be able to use this data in analyzing impact on clinical outcomes. So our primary outcome measure was lung function FEV1 percent predicted. And what you can see in this slide is a kind of lifetime of FEV1 data for one of the kids in our study between the age of 7 here and 13 over here. And our study are between these kind of two vertical lines. And this slide illustrates two terrible things that are wrong with FEV1. Thing one, it is incredibly noisy. And the problem with that, so, we could fairly arbitrarily have taken baseline measures of FEV1 at any point at this start of study, and indeed at any point within a number of weeks at the end of study. And depending on those arbitrary measures, we might have demonstrated a reduction of 16% or 0%, depending on those fairly random days. And so noisy data is a bad business. And then the other thing that's wrong with FEV1 is that there are too few data points. We would have had daily data on everybody, and now we suddenly have a single FEV1 measure every 3 months. And so data science people get very tetchy if there aren't data points that match up with each other. And so the way we chose to deal with this, and I think if you want to hear Nicole Filippo, who developed this system with us, and is a data scientist, she's doing a rapid-fire poster session on Saturday, I think, at midday. So she will explain it a lot more elegantly than me, but we used an individualized best fit polynomial to say what the trajectory was of FEV1 for each of our participants in the study, and then we could have a daily matched theoretical FEV1 that honestly and unnoisily represented the FEV1 journey. But please go listen to Nicole on Saturday. And on that note, you can imagine with 4 million data points of heart rate data, this is a kind of warning, please don't try this at home unless you have a whole bunch of data science people who are on the team with you. At the top in small are physios and physiologists and doctors, but the big pictures here are the data scientists, and so a fantastic group of people who helped us with both the data cleaning pipeline and the analysis. And so what you're looking at in this slide is the kind of take-home of the analysis that happened at the end of this piece of work. It's a linear mixed effect model, and what you're seeing up here are kind of 5 panels of the variables that went into this linear mixed effect model. And the most, I guess, important panel for us up here is a weekly sum of MVPA and FEV1 up here. You can see that there's a relationship, and this was significant. So if your weekly sum of MVPA is greater than your FEV1 is higher. So that's a significant, but at the same time in the model, baseline FEV1 was put in as a measure of disease severity. So if you had a low FEV1 to start with, that would predict what your measures would be. Here, the decimal age is in the model as well. So the older you are, the less your FEV1 in general. Here, your IV antibiotics, the more IV antibiotics you have every year, the lower your FEV1. And here, binary modulated therapy, if you are or are not on modulated therapies, you would have higher or lower FEV1. So all of these things were significant, these variables, they were significant, and they were in the model, and we tested a whole lot of other stuff that was not significant and not seen here. But the point of this slide is that even accounting for severity, IV antibiotics, decimal age, modulated therapies, there was still a significant effect of time in MVPA in your FEV1. So that's a really interesting piece of information to take away. Nicole then did this very interesting thing where she ran the model hundreds of times, and each of these data points involves at least one of the times that she ran the model. And the idea here was to say, well, if you did a minimum amount of MVPA per week, what would the effect size be on your lung function? And you can see over here that if you did less, so this is 25 minutes of MVPA per week, and this is 420 minutes. This is the World Health Organization recommendation down here. And if you did less, so this is about 25 to 150, you would have an effect size that was a bit lower. And if you upped your game and you did more than 150 minutes of MVPA per week, your effect size would be even higher. And to give you a context here, this is 0, and that little blue line over there, if you extrapolate this kind of weekly MVPA, that would turn into about a 3% FEV1 benefit over here. And so this 25 to 150 we took away to mean that you would have a small, but it is statistically significant effect size. But if you did more MVPA per week, this would go up to 4 or 5% plus. But the idea here is it's only fair to extrapolate that to an annual effect if the person who's doing this MVPA does it week in and week out all throughout the year. Consistency is key. And consistency was not a superpower that we came across in our cohort of people, unfortunately. Each of these lines is a participant in the study, and each of the little boxes is a day in the study, and green is good and red is bad, but you get the sense that probably just like you and I, we have good and bad weeks of exercise, sometimes many, many bad weeks of exercise. But that's why it becomes tricky to do this extrapolation game. But the reality is that the relationship exists. And if we put that in another way, we've got this nearly 31,000 days of data, 5,000 weeks of it. And of all of those weeks, 813 weeks were in this kind of bad zone, the kind of less than 25 minutes as a total per week, which didn't show any significant effect on FEV1. We've got about 30% of the weeks that were in the really good zone, more than 150 minutes per week, and just over half in that kind of middle zone of small but statistically significant effect. And so this is quite encouraging in a way, because you might think, oh, well, 30% of the people are doing good exercise. Don't take that away, because actually very few children and young people with CF contributed this 30% of the weeks. Only about 10% of the population contributed 40% of these weeks, and I'll show you that in the next slide. So up here we've got these three panels. These are all the weeks of more than 150 minutes per week. This is the mid zone, 25 to 150, and this is the kind of no effect zone, less than 25. And you can see up here, this is kind of 0 to 64. That's the number of weeks in the study. And we've got one lonely but magnificent creature all the way over here who's contributed actually 150 minutes per week in almost every single week of the study. So they deserve a massive medal. But you can see at this end, there are 30 people here who have never contributed a single week of 150 minutes in the study, and quite a bunch here who contributed 1 week only. So there you go. We've got 10% who achieved more than 28 weeks and who contributed 40% of the good weeks in the study, and only 12 people who managed, every second week throughout the study. So we're getting a sense here that the number of people who are regularly contributing the kind of weeks that would give them benefit are small. And our take home, I guess, from this is that if you can get the horse to the water and make them drink, that there can be some benefits of doing regular, habitual MVPA over 150 minutes per week. And this could have important benefits on lung function people with cystic fibrosis. At the moment, too few people are managing to achieve this regularly. But the other quite interesting little hint here is this idea that the threshold for benefit is so much lower than the 420 minutes that the World Health Organization are suggesting. And an hour a day, I don't know, it's a whole other day for this conversation, whether that's even achievable. But 150 minutes is an average of 21 minutes a day. And that, I think, you can almost talk your patients into having a go. And it doesn't have to be every day, but if you do 42 minutes in a football game on one day, that kind of, it all adds up, as long as towards the end of the week you've got that in. So I'm going to finish there. I want to say thank you to the incredibly marvelous children who participated, to the fabulous physio team, and to our funders, and to literally tens of people who, in the background, helped us with this infrastructure. So thank you very much. Very happy to take questions.
Thank you, Eleanor. This paper is now open for questions. So I got a question for you.
Okay.
Lung function is important,
Yeah,
but it's not everything.
I agree.
So is there any plan to assess different outcomes and that are clinically important as well?
Yes, and I think that becomes more and more important because many children and young people have normal lung function. It's really quite hard to demonstrate an improvement from normal. And also with highly effective modulated therapies, it's going to be even less possible to use lung function as an outcome. And people, tend to have this, I think, convenience approach, which is if I take the pill, I'll be much better, and do I really need to exercise? And obviously, the benefits to exercise in terms of living well are enormous. And so I think this was the hard route, proving benefit of an FEV1. And I think we'd be able to prove more easily benefit in multiple other areas, should we so choose. But it is quite a nice roadmap for understanding and collecting habitual physical activity data over a long period of time, and it doesn't involve much effort wearing a Fitbit. Lots of people do now anyway. And then connecting that to any outcome, in fact, is a very decent roadmap to understanding, collecting huge amounts of data quickly and easily, and understanding other outcomes.
Yeah, I think, this is really hard to do, and I commend you for collecting all this data. If I can make a suggestion, looking at glycemic index, and glycemia, dysglycemia, and these cohorts as they're young, to, I guess, prevent the conversion to CFRD, I think would be huge.
Yeah. And a burdensome study that you're suggesting. And so my recruitment will go way down really quickly, but it's a great idea. Yeah. Are there any other questions? Please ask away. I mean, the interesting, I think, is, starting and ending the day, that both of these studies showed this dose-related effect of moderate to vigorous physical activity. And it's in there somewhere, but there isn't a randomized controlled trial in the world that I can think of that would be able to unpick that dose-related response unless looking at it in this kind of way. So it's a tantalizing hint from two areas of work that both point in the same direction.
You mentioned the finickiness of FEV1.
Yeah.
We do when we're looking at these exercise tests, we're quite frequently looking at their effect on FEV1, and you make a good point that it's quite a bit of a moving target depending on when you take it, what happens on that day, and sometimes we decide whether or not the intervention was successful based on perhaps a moving target. And we look at, we've got the example of the sit-to-stand test where you've got someone with very low FEV1, but it could do significantly more repetitions than someone with better.
Yeah.
And it does make you ask the question, when we're looking at overall quality of life and overall health, are we putting too much on a number? And what do you think about that?
I've thought that for a very long time, that FEV1 is it's a historical concept, isn't it? But if you don't measure it, people will criticize you for it. We have to find the new. LCI is good in pediatrics, particularly because it's a lot more sensitive. But again, it takes, and sometimes if people are severely affected, it's a burdensome outcome measure, and people don't fully understand it. Gemma Stanford's work at Brompton about people's understanding of the outcome measures that are utilized to describe health shows that there's a lot to be done in measuring stuff that people care about. I agree with you a great deal. FEV1, maybe time for something better.
Awesome. Well, thank you.
Okay.
And thank you, everybody, for sticking with us till the end.
Yes, thank you very much to all of our speakers and our audience. We do actually have one announcement. There's a US CFPT meeting tomorrow. Could Julie Christensen come up here and talk about that?
I just want to remind all the PTs from the USA that we do have a meeting tomorrow, and it's going to be right after our first morning session, so it's going to be in room 204 A and B, so like around 9:45 tomorrow morning after the session that's about PT care. Thanks.
Sorry, what was the time again?
It is at 9:45.
9:45, room 204 AB.
So there'll be a PT session going on in that room right before that, and we'll just continue on with our meeting. I think the next session after that we would be missing is more of an RT session, so we figured let's throw that in there instead of doing it at 6:30 a.m. So.
Thank you.
This concludes the exercise workshop. Thank you.